Hello, welcome to the MicroDoc YouTube channel, where we study basic clinical microbiology together. Do you know which is the most important question you should ask your patient when suspecting a Leptospira infection? Watch the video and let me know in the comments if you got it right. The order Spirocetales, from Greek words spira, meaning curl, and kete, meaning hair, consists of two main families of bacteria. The first one is the family Spirocetaceae, which has only two genera, Borrelia and Treponema. The second one is the family Leptospiraceae, of which the only genus is our subject to study today, Leptospira. We'll study Leptospira general characteristics, pathogenesis, and laboratory diagnosis. Let's start with the general characteristics. They are gram-negative, slim, tightly coiled, very mobile, unencapsulated and unsporulated bacteria. One or both ends may be arched, like a question mark. They are strictly aerobic or microaerophils. Even though they are considered gram-negative, they cannot be colored using our usual stains. All species have two periplasmic flagella at each end of the bacterium, inserted in the periplasmic space and not protruding outside the bacteria. They promote leptospiral mobility by alternating clockwise and counterclockwise rotations. I found this beautiful picture of a silver stain from a Leptospira culture. You can clearly see the coiling and the contorted ends. I have a few more beautiful pictures and graphs, you will see them a bit later in the video. The Leptospira genus has two species. The first one is the Leptospira interrogans. It was named interrogans because it usually has only one coiled end, making it look like a question mark. The second one is the Leptospira biflexa. It was named biflexa because it usually has both ends coiled or flexed, and it is a saprophytic bacterium living in the environment, and it does not produce disease in humans. Only Leptospira interrogans can produce disease in humans. It has more than 200 serotypes, but only 3 of them are associated with human disease. The first one is the serovar icterorhemorrhagiae, the second one is serovar canicola, and the third one is serovar pomona. Habitat and source of infection. Leptospiras are bacteria found in the whole world, and the human reservoir infection is an animal that varies with the serovar. For icterorhemorrhagiae is the rat, for canicola is the dog, and for pomona it's the pig. Leptospira mammal hosts can be classified in 3 groups. The first one are the mammalian reservoirs. They have chronic colonization and are asymptomatic carriers. They are mammals who are apparently in good health, but who shed the germs especially through urine and sexual fluids. The second one are the accidental hosts. They get infected accidentally through direct or indirect contact with the urine of maintaining hosts, through skin abrasions, mucosal surfaces, and the conjunctiva. The Leptospiras are very mobile and can penetrate the mucosa. These are humans, domestic animals, and wild cats. The third type of hosts are the amplification hosts. They are accidental hosts in which the infection spreads sporadically, such as domestic animals who get infected accidentally and spread the infection between themselves and the humans. Animals shed germs through urine and waste, contaminating the environment. Human transmission can happen through direct contact, by touching the animals, or through indirect contact through contaminated waters. It is very important to ask our patients during anamnesis specifically about recent contact with dirty water or mud, as well as ask for details about their job, as leptospirosis can sometimes be a professional disease. At-risk personnel includes veterinarians, sewer workers, rice and dairy farmers, and people who practice water sports, particularly during summertime. Pathogenesis, leptospirosis. After reaching the human host through mucosa or small skin breaks, the Leptospiras multiply at an unknown initial site. Non-specific host defenses have zero power in stopping this process, so leptospiremia occurs during acute illness, in the first 7 days. This is very important in a microbiological diagnosis, as it allows the laboratory to process blood samples and give an early diagnosis. Late manifestations of the disease can be caused by the host's immunologic response to infection. Leptospirosis is the most common zoonosis in the world, and its clinical presentation disease varies in gravity and symptomatology. It can present as 3 forms. The first one is the asymptomatic, mild or subclinical form, which is usually underreported. The second one is the anicteric syndrome, which is a simple flu-like syndrome with non-specific symptomatology and biphasic evolution. It debuts with sudden headaches, coughing, fever, non-pruritic rash, muscle pain, anorexia, and diarrhea. This form of disease is rarely fatal and represents more than 90% of all documented cases of leptospirosis. It may have a recurrence after several days, a second phase of the disease known as aseptic meningitis. Patients usually recover fully but may suffer from residual chronic headaches. The third form of disease is the icteric syndrome, which is also called Weil's disease. It happens in 5 to 10% of cases. It is the most severe form of leptospirosis, manifesting with fever, renal failure, jaundice, pulmonary hemorrhages, and severe respiratory distress. We call this the hepatorenal pulmonary involvement. It has a long course of weeks to months, but evolution is generally favorable with treatment. It has an incubation phase of on average of 2 to 20 days. It debuts with fever, chills, and meningeal syndrome. After 1 week of disease, the patients will present jaundice and renal failure, getting worse every day. The fever drops. After the first week, a new fever episode may appear, which lasts for approximately 5 days. I like this figure because it shows clearly the differences between the anicteric and icteric forms of leptospirosis. First, we can see the biphasic character of the fever in the anicteric syndrome. In the second case, we can clearly see how the fever may reappear after the first 5 to 7 days of disease, and it lasts for a few days before decreasing. Laboratory diagnosis. It is both bacteriological and serological. Clinical samples vary with the moment of disease. Thus, you can collect blood during the first week of disease, when the organisms are only in the bloodstream transiently before they sequester into tissues and become undetectable in the blood. We can also collect blood at any time to check for antibodies. Cerebrospinal fluid. You can collect CSF after the first days of the disease. And urine. You can collect urine starting with the second week of the disease once the organisms leave the bloodstream and become established in the renal tubules. Why do you need to know this? Because collecting the right patient sample at the right time will tremendously increase the sensibility of laboratory tests and, in consequence, your chance of getting a right etiological diagnosis as soon as possible. An ideal submission of patient samples is whole blood serum and maybe CSF during the first week of acute illness and serum and urine during convalescent illness. This very useful figure shows us the bacterial load evolution and antibody titers during the course of the disease. As we can clearly see, during the first week the bacterial load is growing in the blood, whilst after the first 3 to 5 days of disease the bacteremia decreases and the bacterial load in urine increases. Of course, these are approximations, as every patient is different, but we need to try as much as we can to find the right moment for the right clinical sample. On a funny note, wouldn't it be nice if the bacteria could just send us an email letting us know about the exact moment it decides to move? Like, hey, I packed everything on day 4 and I'm moving to the kidneys. Take a urine sample in a few hours. Now that we have our clinical sample, what are we going to do with it? The first step is doing a direct microscopy. As leptospiras are very thin, the normal optical microscopy does not have the capacity to see them. Gram stains, silver stains, dark field microscopy, and phase contrast microscopy may help, but they are not very useful as they have a high rate of false positive results due to artifacts and require a high level of expertise. The best method to see the bacteria on a smear is the direct immunofluorescence assay. However, this method is expensive and is not available in most laboratories. This beautiful picture shows leptospiras in dark field microscopy. You can clearly see the contorted ends. Here we can see other examples of dark field microscopy and fluorescent staining of Leptospira interrogans. The second step of our laboratory diagnosis is trying to isolate the bacteria in cultures. The best results in recovering Leptospiras occur when fresh specimens are inoculated directly into laboratory media. They grow slowly and need a 6-week incubation period at 28-30 degrees Celsius. The media can be incubated in a dark room at room temperature. They grow in selective media, for example Fletcher semi-solid medium or EMJH semi-solid medium. For identification, traditionally, microscopic agglutination tests are used to serotype strains from the patient's serum. More recently though, laboratories with more advanced technology can use 16S ribosomal nucleic acid sequencing and multi-TOF mass spectrometry in order to accurately identify the species of Leptospira from cultures. In what concerns the molecular diagnosis, many molecular assays have been developed to detect pathogenic Leptospira DNA in clinical samples. However, detecting the DNA in blood or tissues is diagnostic for infection, while detecting it in kidney tissue or urine may represent an infection or just colonization. Other tissues besides kidney, such as liver, spleen, lung, placenta, and brain tissue, can be infected with Leptospira species in ill patients. Cerebrospinal fluid is an appropriate specimen for molecular diagnosis if the patient is experiencing signs of meningitis, and ocular fluid can be used as a diagnostic specimen in cases of uveitis and conjunctivitis. PCR and real-time PCR have the advantage of providing a fast diagnosis in the acute stage before the appearance of IgM antibodies, when treatment is the most beneficial for the patient. If you can have the positive diagnosis even 1 day earlier, it can make a great difference for the patient. Serology. It is a very important step in the microbiological diagnosis, as most cases of leptospirosis are diagnosed by serology. Usual immunological assays may be used in detecting Leptospira antibodies, with the gold standard being the microscopic agglutination test. Other methods include immunofluorescence, indirect hemagglutination, latex agglutination, lateral flow assays, and the IgM dipstick. IgM antibodies can be detected after 1 week of disease and generally persist in high titers for weeks to months, while IgG antibodies are usually detectable 1 month or more after the infection. Antimicrobial susceptibility testing and treatment. Susceptibility testing of Leptospira is not normally performed in the clinical laboratory, as the bacteria are still susceptible to tetracycline, doxycycline, macrolides, penicillin, and ceftriaxone. So, this is all you need to know about Leptospira infections, in less than 15 minutes. If you enjoyed this video, subscribe to the MicroDoc channel. It is easier to learn clinical microbiology if we do it together.